Hey, Shauna, how many of your clients have joint issues like frozen shoulder or knee arthritis or some other kind of joint achy going on?
There are more than I can count. And I'm so happy today to have Dr. Jocelyn Wittstein with us. She is an orthopedic surgeon specializing in sports medicine. She's a former collegiate gymnast and an associate professor of orthopedic surgery at Duke University. And she has a lot of great answers for us.
Yeah, and before we get in this conversation, we do want to give a shout out to a Girls Talk Healthy Aging listener, Miss Emily Bradley. Thanks for listening, and let's dive in. Welcome to the Girls Talk Healthy Aging podcast, where we dive deep into pressing health and fitness issues facing aging women. I'm Allie Kerr.
And I'm Shauna Kaminsky. And together we'll bring candid conversations, expert advice, and personal stories that will inspire and empower you on your own wellness journey.
Well, we are so happy to have you. Welcome, Jocelyn, to the podcast.
Thanks for having me.
What inspired you to become an orthopedic surgeon? Like, what led you to take this specialty? And you're really focusing on women's health, which I love.
It's funny. This is a very common question, and we ask it of all the people that we interview too, who are applying to go into orthopedics. And for a lot of people, sports participation is kind of a gateway to orthopedic surgery. you you end up learning a lot about musculoskeletal health, sometimes through your own injuries or sports participation. You often see maybe a physical therapist or a doctor, and then it sort of strikes up an interest. And once you're in medical school, if you don't already, want to be an orthopedic surgeon, I think a lot of athletes kind of have that bent. So specifically, I actually went to medical school, though, originally thinking I wanted to be a pediatrician, and then kind of very quickly realized I wanted to do more of a surgical subspecialty. And then once I figured that out, it was very obvious to me that I had such a musculoskeletal interest. And then with each level, I always talk about medical training as being sort of chunks of time. You've got medical school, and then you've got residency once you decide to be an orthopedic surgeon. And then once you're within that, you kind of decide what you want to do as a subspecialist. And I ended up going into sports medicine, and then even more specialized within that. I really love caring for female athletes really across the lifespan. So it can be a young athlete or 40-year-old runner, or you could be a master's athlete. And it's like a whole span. So
I love that you enjoy working with athletes, because we need people that can understand, because so many times people think of like orthopedics or having surgery as that's going to take you out of sport or being active. And so it's nice to have folks in the field and you're a former athlete. So can you tell us about your athletic background? Because that's pretty amazing.
Yeah, I was a gymnast, and as anyone knows, if you were a competitive gymnast, you don't do any other sports. So
Yeah,
I
that's pretty
can't.
hardcore.
Yeah, I can't catch a ball, but I can do an aerial cartwheel. But it's just one of those sports that's very time consuming and specialized, and but a lot of whole body strength and good bone density, because there's a lot of impact on your upper and lower extremities. But yeah, a lot of people think the field of orthopedic surgery is only about surgery. We do a lot of surgery that sort of, restores function of your tendons or your ligaments or your joints. But there are a lot of things that don't need surgery, actually. And actually more things that don't need surgery than do, really.
Hmm.
I was just going to say that I think you still can do an aerial. I think I saw something on your Instagram that you recently did an
Yes,
aerial.
I did one maybe a month ago just to test myself. But yeah.
It's pretty amazing. Did you sustain any, gymnasts are known for injury. Did you sustain any serious injuries along the way?
Nothing too serious, ankle sprain here or there, or actually when I was in college I had like a minor disc herniation off to one side just from something stupid. But I I didn't have any major ligament injuries. A lot of times you have a lot of teammates. I had teammates who had some, knee injuries, ACL tears, maybe a stress fracture in their spine, things like that. So all sports have their injuries. It's just each sport has their classic injury. It's like soccer, it's ACL tears, and baseball, it's the UCL. So each sport has their characteristic kind of weak spot for sure.
So, what would you say you're seeing as the most common issue with women, 40 plus?
Mm-hmm. So I mean, depending on the joint, I think in our 40s we start to see more joint inflammation, and so kind of honestly between the age of 40 and 60, I would just sort of lump together maybe what's most common is the most common thing I see is frozen shoulder. And then I would say second to that is like early onset knee arthritis. So that kind of inflammation and swelling that's activity dependent, but kind of normal looking x-rays, like the very earliest versions of arthritis. And knee arthritis isn't unique to women, but it's much more common in women. And it certainly happens to women at an earlier phase than happens to men. And then frozen shoulder really is not 100% unique to women, but it has a strong predilection for women between the age of 40 and 60 and perimenopause and menopause. So those are really, in women over 40, those are the two most common conditions that we see.
And with frozen shoulder, that sounds like the biggie. I mean, I'm thinking our listeners would be asking why. Why is that? Can you give us some insight on what's going on with our shoulders? Or one shoulder? It's typically just the one. I mean, it's typically.
Well, you can often actually get it on the other side after it resolves on the first side, but luckily when people have it on one side, they tend to pretty quickly recognize it when it's happening on the other. So, but yeah, it's probably related to changes in estrogen levels and estrogen withdrawal. Usually people, end up with a frozen shoulder after almost no trauma. Really, it can be something very minimal, like someone might notice maybe their dog was pulling on the leash a little bit, or really nothing at all. Sometimes people just wake up with their arms stiff and frozen. And this is almost always women between the age of 40 and 60. And so often these women are having other things going on, like hot flashes or night sweats, or, some signs of fluctuating estrogen levels. And we know that the shoulder joint is very sensitive to estrogen withdrawal. And that's something I initially learned years ago, treating patients who are also dealing with breast cancer and taking medications that, basically are eliminating the effect of estrogen in their body, right? And having joint pain and frozen shoulder. And I sort of first started thinking about that process years ago through that patient population and helping them with frozen shoulder and treating them with injections to help them get over it. But likewise, you see in women who are going through estrogen withdrawal as part of menopause, this increased inflammation and freezing up of the shoulder. And there are definitely basic science studies that have shown us that one of the things that estrogen does is it inhibits inflammation in the joint, but it also inhibits some cells in the lining of the joint called fibroblasts that can make it thicker and more rigid. So it's just something that women are really more prone to, and something that if recognized early can be very well treated and reversed with actually a steroid injection.
So aside from like a steroid injection because it's set in, is there anything preventative that we can do to avoid frozen shoulder?
We're going to interrupt this interview for just a second because we've got something we want to make sure that you know. If you're struggling with your health, with your fitness, if you don't know where to start or you know what to do and you're not doing it, we're here for you. And all you need to do to get our help is to reach out to Shauna and I at our email, sapodcast23@gmail.com. And we're happy to help and we will be in touch. Now back to the show.
Well, that's a good question and something that I've tried to study and explore, and I haven't fully established this yet, but I based on some, I would say, my experience with my patients and some information that I have from previous studies and ongoing studies, I do have the general sense that women who initiate hormone therapy earlier, if they're able to, again, not everyone can because some people have contraindications and can't, but I do think that probably reduces your risk. Just knowing the basic science and, mechanisms that seem to lead to frozen shoulder. That's certainly not one of the, FDA approved indications for estradiol therapy, but I think that it probably does reduce risk. More to come on that. I have ongoing studies on that, but that's sort of where I lean kind of through my experience and sort of knowledge of patients on aromatase inhibitors, patients like with and without hormone therapy, some of the research that I'm doing. But I think we're still learning, and that's not definitive, but I think that's sort of where I'm leaning.
And can you speak to the studies? Because I think sometimes those of us that don't work in research, we don't always know kind of how hard some of these things can be to study, and especially when you're dealing with someone on hormone therapy or not. I mean, how do you study that?
Well, like for instance, we could look back at our population and look at all of the menopausal women who were using hormone therapy or not, that included systemic estradiol, and look at like what were the rates at which women without hormone therapy developed frozen shoulder. And I presented a study on that at the North American Menopause Society. And one of the challenges of looking at that data is that, a very small percentage of people in the United States actually use hormone therapy, about 4.5%. And so when you're looking at just a kind of a non-curated population, you have like a really large number of people that are not using hormone therapy, and then a really small percentage of people that are. And you need large populations to study that better, because when one group is so small, even if that one group that's so small, the hormone therapy group, has a very small number of cases of frozen shoulder, it's hard to draw conclusions sometimes because that number is just so small. So like I said, I have some ongoing work in this area that hopefully we'll be able to publish in the near future. But that is one of the challenges of studying like a condition that you have uneven subject groups, I guess I would say. So, but there are also other basic science, data points that if you kind of put them all together like a geometric proof, it would make sense. Like we know that aromatase inhibitors cause joint pain, and we see more frozen shoulder in that group. And we know that that the menopausal state is associated with, inflammatory cytokines. And we know through some basic science studies that there are estrogen receptors in joint capsules that affect inflammation in the joint. And we know through other basic science studies that estrogen can inhibit fibroblasts, those cells that thicken the lining of the joint. So when you kind of put all those pieces together, that makes a lot of sense. But we need more information. We're actually studying large populations of people prospectively to like be, more definitive about these statements for sure. So.
And maybe over time, more people are leaning towards menopause hormone therapy. It's just getting a lot more attention. And so maybe that sample size over time will grow. So that will make your studying a little easier. I don't know about that.
Yeah. I have a registry that we follow patients prospectively now in collaboration with some of our women's health providers, and kind of tracking symptoms of joint pain and timing of onset of use of hormone therapy or not, and progression or new onset musculoskeletal symptoms or not, and just in a really detailed level. So, we keep working on that, but we do know, even from like the earliest studies of the Women's Health Initiative that, nearly 80% of people had joint pain, in at menopause, and that use of hormone therapy reduced, the number and severity of painful joints, and then withdrawal of hormone therapy was associated with the rebound of some of those symptoms. That we know those things. So, the shoulder, I think, is one of those joints that's affected, but like likewise, I think one of the other joints that we just see a lot of effects of, systemic inflammation on in women is the knees, and risk of knee arthritis. So I think there's a lot of data that like points us in the direction, of course, that the menopausal state or estrogen withdrawal. Maybe that's, because you're having to be on aromatase inhibitors, or you're a woman that's going through natural menopause, but you can't take hormone therapy. That those states are states that are going to be more prone to things like progression of knee arthritis or joints being symptomatic or a frozen shoulder. So there's a lot of data being shed on that now, and I think more and more to come. But as I mentioned earlier, joint pain, inflammation, frozen shoulder, those are not truly the indications for use of hormone therapy. But I do think that they are things that are ameliorated by by hormone therapy.
And do we know like age of like when people are starting that hormone therapy? Are there any connections with that? Someone who starts maybe earlier versus someone who starts later, as to if that
I think hopefully we'll learn more over time. Yeah, like, do women who start using estradiol in perimenopause, are they less likely to progress to have more significant arthritis in their 50s than someone who waits until 52 as compared to someone who's never able to or decides to never use hormone therapy? Like, these are some unanswered questions. What level of estrogen supplementation do you need? We have a fair amount of data that even lower doses of estradiol can positively impact bone health, but I think we need to learn more about how different levels of estradiol therapy and when you would start it, how that might affect joint health. So I think there will be a lot more information to come in coming years on some of these topics for sure.
Yeah. And with the shoulder, how would someone know that to catch that early? Like, what symptoms? It sounds like you say, like, hey, you might just be walking the dog, or you can wake up with it. And how long before people actually come to see you once they start experiencing symptoms? And how soon should they come to see?
Yeah, I mean, I'm always surprised at how long people tolerate a stiff joint. Like,
Especially women.
if I woke up one day and I couldn't move my arm, I would be alarmed. But sometimes people come to see me and they're like, well, it's been this stiff for months. And I can't imagine waiting that long. But like, I tell people, if you didn't have a traumatic event and you have sudden loss of range of motion in your shoulder, like, go in as soon as you can, because the sooner you make an intervention, the better. Now, usually the lack of motion, the stiffness kind of is preceded by some painful phase where it's not totally stiff, but it's all of a sudden painful for no reason. And then it gets very stiff. And ideally, you would even get to it before it gets stiff, but it's even harder to catch it then because people will just put up with pain. But if you have sudden loss of motion, you should go see an orthopedic surgeon or a primary care sports medicine doctor that can do an injection into your joint as soon as you can, because that's how you hopefully reverse it and stop it from getting worse. Otherwise, it'll kind of freeze up and take a long time to thaw out.
So if you are more active, would that help to alleviate or prevent frozen shoulder?
Not really. I mean, there's some association with diabetes, but there's also some association with thyroid conditions, but it's not really. You could be an athlete, be a sedentary person. I had frozen shoulder last year, and I'm a very active person.
Yeah.
It's just the group of people that it affects are generally women aged 40 to 60, and I'm 47. So I'm not immune to it either.
So it really is, it doesn't matter then. I mean, it's always better to keep moving, but that won't necessarily.
Yeah. Oh yeah. I mean, for other reasons, but not for frozen shoulder prevention. No. Yeah.
Okay. Good point. So, we are obviously, all three of us, advocates of moving and resistance training. I would just like to be able to say, well, it would also help prevent frozen shoulder, but because it might be because of the loss of estrogen and the anti-inflammatory properties that it provides, then even movement isn't going to help.
Yeah, I just think recognizing it early and getting it treated is good because it's very treatable.
Yeah.
It's harder to treat when people wait a long time to come in, and then it's just really, really stiff and already kind of frozen, and then we can help with pain, but then it just has to thaw out, and that's very frustrating to people. That takes a
So
long.
is the treatment basically a cortisone shot?
Yeah, this is one of the few conditions where like a cortisone injection is like a cure for the problem. And sometimes maybe repeating it one time, but an early intervention with a cortisone injection into the joint is actually can be a permanent cure for this condition. It may come back on the other side. You can get on the other side, and rarely someone will have a recurrence on the same side, but usually interrupting that process will help it, resolve quickly.
And with frozen shoulder, and you talked about knees, because I know Sean and I work with ladies in a fitness environment, and I see a lot of knees, a lot of knee problems and shoulders. So those two. How would someone, I mean, obviously they need to come see you if they are not sure, like, okay, with my shoulder, is it a frozen shoulder? Or, I'm guessing one thing would be like, did you actually do something that injured their shoulder? And sometimes people in their mind did something, but it was not something that would really cause normally that kind of pain or discomfort. If they're just, maybe they did have a dumbbell in their hand, but maybe that was like a 5 pound dumbbell and they did this and all of a sudden they're feeling their shoulder. Would that be
Yeah,
something
I
that is?
think regardless of how you hurt or didn't hurt your shoulder, loss of range of motion is a reason to go get checked out. If you're like a woman between the age of 40 and 60, I mean, you're just that's the number one thing on the what we call differential diagnosis. Yeah, if you had an injury, there could be something else going on. It doesn't mean you're like immune to something else like tendonitis or rotator cuff tear, but if you didn't have a major traumatic event or you didn't even think you really overused your shoulder, that's the most likely thing to be going on.
Yeah.
And would you recommend, like, as a part of your practice, when a patient comes in with frozen shoulder or very sore knees, would you be one that would recommend menopause hormone therapy, or would you suggest that they talk to their primary practitioner?
I try to be fairly holistic and talking to a patient and see what else is going on with them. Like I work in a network where a lot of people's care is kind of within the network. And of course I can see like, and whenever you talk to a patient, you're like meeting them and learning what other medical problems they have. And, occasionally I'll see something like, oh, you were recently started on Lipitor, or, oh, I see you just got started on medication because your hemoglobin A1C was creeping up. And, maybe they're also being given like a sleep medication or having some anxiety or something like that. And when you sometimes you can sort of see a whole picture of a person. And then they also say they're having, like hot flashes and night sweats and things like that. If you kind of put all like the symptoms together, sometimes you can imagine, there might be a common root, which could be perimenopause or menopause. And so I frequently offer to and do refer my patients to my women's health colleagues who can assess them and, prescribe. Maybe they may be receiving some form of estradiol plus or minus progesterone. And, so I think, yes, I do consider in many cases new onset frozen shoulder to be potentially a symptom of menopause. And I don't prescribe these medications, but I do want to collaborate with those who do. And if the patient is having a bunch of other things going on that seem, related to perimenopause or menopause, I'm happy to have that discussion with them and help refer them and make sure they're kind of getting the whole picture treated. And we do that a lot. And my women's health colleagues frequently will send frozen shoulder patients to me because they're seeing them for other conditions. And then they're like, oh, you need to go see, Dr. Wittstein so she can inject your shoulder. So I think the key is like seeing people as a whole person, not practicing in a very siloed way, and having your people and other subspecialties that you can help kind of ferry your patients to. So
Yeah, and you have your Dr. Winston, you have your patients that you're seeing, and you're busy, and you're doing research, and you're teaching others about orthopedics. How do you have time to get involved in social media, and what made you decide to get on
oh
social media? I want to hear about this side of your, because that's work.
yeah, Yeah, I'm really not actually a big social media person. I did not know how to use Instagram before January of this year, and my 19-year-old daughter, uh, you know, helped me whip together a little account, and I was kind of paying her like $50 a week to help me. She kind of showed me how to make some videos, and honestly I was very confused about what is the difference between a story and a reel and a post, and she tolerated me for quite a while and like kind of showed me how to use it. And the thing is, I just share things that I'm reading about or writing about anyway. If I'm working on a paper or a grant application that's related to cartilage health and knees of menopausal women, for me, I'm reading these things anyways. I'm writing sections of a grant or a paper. It's very easy for me to just kind of translate when I'm reading to a non-medical person in a sort of bite-sized kind of way and just share the information. And so if I'm, preparing a presentation for an academic meeting and I'm reading a new study or reviewing an old study I just haven't looked at in a while, it's very easy for me to, again, just translate it and share it with people. So obviously I can read all the studies I want and keep that information to myself. But I think there's so much information that's in complex or just medical jargon literature that can be made more accessible to people if it's just translated. And I don't mean not translated as if I'm not speaking down to people who aren't medical people, just honestly, just making it digestible to people. Uh, and the other things I share are often things that I'm doing anyway. Like I'm making this thing that I'm going to eat, and I can educate someone about why I'm eating it,
Yeah.
or I'm doing this exercise anyway for my bone health. I can share why
Yeah.
I'm doing it. So it's actually not that hard to add on. And I have enjoyed helping people, and it's a new dimension to helping people. I'm used to helping people one on one, and I've gotten a lot of very appreciative messages, from people, and so I'll keep sharing translated medical things, hopefully in an understandable way. So,
Well, I mean, full disclosure, that's how I found you. I
mhm.
love your account. It's very accessible, and I always say it's always no unless you ask. So I reached out to you, and
Mhm.
I think it is a public service that you're doing, because maybe by providing some of this information, you will have less, not that not that you want less patients, you want to have a
Yeah.
job, but
Oh,
honestly,
I would love for people to have less frozen shoulder, or it's actually the most frustrated patients are patients that are what I call tweeners. They're in between interventions. So, and that ends up being, like a lot of, say, like women and their, I mean, I see every day in clinic like 52-year-old women with knee pain with mild arthritis. And they're like, every time I do what I want to do, my knee swells. And I look at their MRI, and there's really not a great target for arthroscopic surgery. Like, they don't need a meniscus repair or debridement. They just have some early cartilage thinning, but they also don't need a knee replacement. And, maybe injections and anti-inflammatories aren't making them feel totally great. But at the same time, there's not like a great solution. Their arthritis isn't bad enough to need a knee replacement. I'm not going to make them better with an arthroscopy. I would love to have less patients like that, where if we could somehow, help people not end up in that position. Now, do we have a way to like prevent arthritis? No, but I really feel like more literature is going to come out about more cartilage protective effects of 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 kind of graduated hormone therapy and perimenopause and menopause. The group of people I would love to be able to do for, which is just so hard, is patients who can't use hormone therapy. Um, our patients who are on aromatase inhibitors or then tamoxifen, and our patients with early surgical menopause who may or may not subsequently make a shared decision to use hormone therapy. But like, it's just, I think one of the hard things about trying to advance women's health research is that sometimes the things that you're finding that can help some people can't help everyone. And so, yeah, long-winded answer, but in general, I would love for people to have less joint pain and less frozen shoulder. There's enough people just hurting themselves. I say all the time, I haven't met my patients who need surgery 2 weeks from now because they haven't hurt themselves yet.
Mhm.
They haven't dislocated their patella or torn their ACL or torn their rotator cuff. So orthopedics everywhere would love to have less patients who have less pain that are not in need of surgery.
Yeah, that's tough because what's like, what do you do? I mean, what are their options if they're tweeners?
Yeah, symptom management. And there are a lot of things that can be done, like for knee arthritis that doesn't yet need a knee replacement or, isn't going to benefit from arthroscopy. There are a lot of things we can do to help symptoms. The hardest thing that may slow progression of arthritis is weight loss. That's really hard for people because it's hard for them to exercise if their knees are feeling bad. We can use injections sparingly. There are lubricating type injections called viscosupplementation that help some people. I do think that collagen supplementation can help people with joint pain. A lot of times I tell people to try a turmeric supplement. There's some pretty reasonable evidence behind that as an anti-inflammatory. Taking a higher dose vitamin D supplement may help. There's some evidence that omega-3, fish oil supplementation may help if you don't get a lot of omega-3s. An anti-inflammatory diet, there are all kinds of things that we can try to do to reduce joint pain. A lot of it comes down to changing your activities sometimes, like picking and choosing or moderating, how much pickleball you play, not 2 hours every day, things like that. So, when someone isn't a candidate for, they don't need a knee replacement yet, but a knee scope isn't going to help them. Basically, we're trying to help them navigate their symptoms, and then later on in life, they might need something like that. So that gets to that point. Like so many people in orthopedics, like don't actually need surgery; they need help navigating, more or
Mhm.
less.
Pain management and life management of how to
Yeah,
get
symptom
around and
control.
live their best life. What about exercise and strength training in particular? How, especially with women, because that's our target audience here, that's become more of a buzz in the social media realm and in the just in media in general. We're hearing more and more about women doing strength training, and I know Sean and I are glad to hear more about it. But I'd love to hear from you what your thoughts are as far as strength training. What that is, that something that's
Yeah.
helpful? When should we start? How often should we? What are your
Well,
thoughts?
strength training has, tons of benefits, not only to your metabolic health and, helping to reduce insulin resistance, but also, of course, increasing your bone density. The heavier you're lifting, the larger the impact in terms of maintaining or improving your bone density. But I always tell my patients, having lifting isn't for everyone. We know from studies that even postmenopausal women with osteopenia can build up to heavy lifting. But for instance, you're an individual, if you have like really bad knees, you're probably not going to do like super heavy squatting. But maybe you can do heavier deadlifting. Or if you have a shoulder problem, like you had a rotator cuff repair years ago, you're not going to do very heavy overhead pressing. So yeah, strength training is great for building and maintaining bone density. I think that, people do need to start at a lower intensity and build up, to do that safely. And then I kind of always want people to know that if you can't do that really high intensity strength training, there's still benefit to the less intense levels. It's not going to be as much, but it's still worth doing. And I think that in general, as we get older, we need to think like that. It's not that you have to plan on doing less as you get older, but you do need to, listen to your body. And, if you have an arthritic joint or a former, tendon repair or something like that, I think it's okay to respect those things and kind of try to thread the needle between, like, yes, you want to build muscle mass and maintain or build bone density, but sometimes we have to listen a little bit to our achy joints.
That balance. Yeah.
Mm-hmm.
I
Yeah.
get a little frustrated with some of the influencers and message that is out there that you must lift heavy, because light lifting is also beneficial. And I think it's disempowering to those people that maybe are suffering from joint issues
Yeah, I think it's important for like fitness to not feel exclusive. I mean, I see people too doing things I'm like, oh, I can't do that,
Right.
or I wish I could do unlimited pull-ups. I can do pull-ups, but if I do more than 15, like 3 sets of 5 in a routine manner, I know myself, I actually get really bad tendonitis. So,
Oh, yeah.
and that's not like a small goal, but for me, it's a limitation. And I think it's okay for me to accept
Mm.
a limitation, and because I
You know
can't,
your body now,
I
and
know my body. Yeah. And so yeah, I think the messaging is meant well, and for people to like hear and see. Like the data does show that high intensity strength training, which is something where like you're doing your exercises in sets of 4, where like the 4th, 5th, or 6th rep is like basically the last one that you could do in that set with still maintaining good form. So which would correspond to something like your 80% of your single rep max, right? That high intensity strength training, it does stimulate greater bone density than kind of a more moderate amount or a lighter lifting. But again, it doesn't mean the other forms lack benefit. I kind of liken this to walking, or sometimes where people say, well, walking doesn't stimulate bone density. Well, true, it's not like creating enough impact force to stimulate like new bone formation, but walking is better than being sedentary,
yeah,
and better than, I always use the expression, being an astronaut. If there's just like literally not weight on your legs,
yeah,
or if you were on crutches for 6 weeks, even being on crutches for 6 weeks or having a leg surgery can diminish your bone density in the affected leg for a couple of years. So there's, disuse and there's use. And I think use to tolerance, or I like to say weight bearers tolerated. We say that in orthopedics all the time as a sort of post-op restriction or not, but you have to do what you can tolerate. And we all know if you do more than you can tolerate, then sometimes it can be a setback for you. So I don't ever want to like diminish things that people can do, because sometimes that's what they can do. I do like the idea of like challenging yourself, maybe with some guidance and some help, and people often can do more than they're doing, and some of that comes from like fear of movement. Like people with knee arthritis often have like what we call kinesiophobia. They're like afraid to do a movement or afraid to do something that requires agility, because they're fearing the pain they might experience. They might not actually experience the pain, but there are some studies that show that actually there's that fear of movement sometimes inhibits people from activity even more than the actual pain. And
absolutely.
so I do think sometimes people could do more than they're pushing themselves to do. On the other hand, we can't necessarily like expect everyone to be able to do the heaviest lifting all the time. And if you can, that's great. But it's okay if you can't.
Yeah,
and
and
maybe,
that fear thing is so real. If someone, especially if they've had some injury or surgery, so I would love to hear your thoughts on how to get back into an exercise routine. Let's say you've had some kind of injury and you've had some kind of surgery. What is the, and I know, of course, it's going to be patient dependent as to what your, I would think, recommendations. Although Sean and I in the fitness field, we kind of hear a lot of kind of standard, like a certain doctor, if this person goes to this knee surgeon, we're going to hear this recommendation no matter, what patient it is. But for you, how do you get patients back to activity, or if they weren't active, to activity? And how soon are you encouraging them to not be afraid and get out
Well,
there?
it completely depends on the injury. I will say, no matter what the procedure or injury that someone has experienced, I always try to think of ways that they can safely be active in any phase. So, if I did your ACL reconstruction surgery on your right knee, I would be fine for you to go to the gym and do left leg exercises and stimulate some,
Mm-hmm.
neuromuscular cross education, or not lose muscle mass on that side. Create the, response in your body to strength training, which has other side benefits, right? Like, use your arms. I mean, I had my own hip surgery last July, and all I could do is think of what can I do right now, and that's kind of what I do for my patients too. And like, I wasn't supposed to be doing a lot with my hip at first, so I got on an air bike where I could move the two arms and one leg, and I just did biking, 3-limb biking, I call it. And I would do that like an hour a day because I could. And so in any phase, like I tell, if I have a patient with weight bearing restrictions, I'm trying to get them to at least do stuff with the other 3 limbs. If you're, um, what if you're a teenager wanting to go back to basketball? Well, maybe earlier on I can send you and you can just do like some stationary shooting, but you're not doing layups. Um, there's all kinds of examples of just modifying things, but graduating you back to parts of your sport. But I think the main thing is like helping people not lose cardiovascular fitness while they're injured. And there's so many ways around that. Like, again, I just told you about 3-limb biking, or you could do a ski erg many times, or, and even an arm bike. It can be hard to get your heart rate up, but I think maintaining, not getting cardiovascularly deconditioned when you're injured, if you can help it, strengthening around your injury, and then just with each phase of recovery, adding back, and then ultimately the key to getting back to activities is you need like good mobility, you need good strength, balance and agility. And there can still be sometimes that what we call fear of movement or kinesiophobia. And honestly, sometimes that's protective. I think sometimes if someone still has some fear of movement, or fear of returning to an activity, it's because they're maybe not ready yet. And I wouldn't ever try to force someone or tell them to ignore their fear, because sometimes it's actually self-protective. You might just not be ready for that activity yet.
I love that you are suggesting to focus on what you can do, and that's always what I suggest. I've had both hips replaced, and I just started training right away and just focused on the things I could do. I'm so thankful for medical technology and what you people do, because I have my life back. So,
Yeah, hip replacement surgeries are the most successful orthopedic
ah,
surgery like ever created.
yes,
I
they,
don't have a hip replacement. I had a labral repair from probably an
uh,
old injury, but they're certainly totally life changing for people.
yeah, yeah, and I would agree that it. I mean, I don't know anything about surgery other than being on the receiving end of it, but
Yeah.
having that it's muscle sparing. At the same time, my best friend in Australia has had both knees replaced, and I'm like, I will choose hips over knees for recovery.
Yeah, it's a little harder. Yeah, yeah.
Right? Like the
Yeah.
recovery, we were basically recovering like 2 weeks apart from each other, and my recovery was skyrocketing. And I'm like,
Mm.
look, don't worry, it's not you, it's just the surgery. So
Knees are harder than hips to recover from.
yeah.
That's true.
I wanted to ask about jumping and bone density. And there is a study about it's a 2015 study talking about 20 jumps, 2 times, 10 to 20 jumps twice daily with 30 seconds rest is supposed to help with bone density. Is this something that you would agree does help with
Yeah. Yeah,
density?
I mean, I definitely try to incorporate jumping and impact. Now again, we get into some people, it's not for everybody. Like if you've got like bad knee arthritis, not for everybody,
Wow.
because you might aggravate your knee. And there are like ways to work around that. Likewise, if you have like severe osteoporosis and history of fractures, and you haven't been doing, like, everyone's different. Like, one extreme would be someone who's like severe osteoporosis and they've never done any jumping. They're not a regular exerciser. I wouldn't go tell them to jump off an 8-inch step.
Yeah.
But what if you're someone who's been doing this for years and you're just kind of having some gradual decline of your bone density, but maybe you've got pretty reasonable bone architecture and muscular architecture, because that's been part of your regular routine forever, would I tell you to stop? No. So, but in any case, yeah, I do think, the data is pretty clear that strength training that involves like carrying and pushing overhead and lifting weights has a larger impact on lumbar spine bone density than the hip, but also some impact on hip bone density in a positive way. But jumping and impact primarily benefits the hip region, more so than the spine region. So I think if most programs aimed at exercise for enhancing or increasing bone density involve combination of resistance exercise plus some impact training, and then other things like agility and balance, for fall prevention. Those are kind of general, fracture prevention principles. But definitely, I think that jumping stimulates and helps to improve hip bone density. There's some evidence to suggest that it's more effective in premenopausal than postmenopausal women, but I still think it benefits postmenopausal women. And it doesn't have to be crazy jumping. Like, you want to generate some pretty good impact. So like I've demonstrated some of the work, like there's a brilliant lady named Tracy Clissold who's done lots of studies on this and shown you can do like a squat jump with a rebound. You could drop off an 8-inch step and then do a rebound. You could also do what's called heel drops and create some impact if you're someone who can't jump. I like to jump rope. Jumping rope isn't as much impact as one of these drop jumps with a rebound, but and depending on how you jump, it's more or less impact. So, but I think jumping and anything that creates impact is good. I always get the question, but my knees hurt when I do that. Like, should I jump if my knees hurt, or should I jump if I've had knee replacements or hip replacements? And I think in regard to the hip or knee replacements, I think most arthroplasty surgeons would be okay with you doing like 20 or 30 jumps a few days a week. And are they going to want you to go like run a marathon? No. But it's also good to maintain your bone density around those implants. You could always talk to your surgeon, and everybody's knee or hip or every individual's unique, of course. For the arthritic knee or hip group, if that jumping hurts, maybe try the heel drops instead. If that's not working for you, there's reasonable evidence that you could try jumping on a rebounder, like a small trampoline. It probably does not do as much as land-based jumping, but does something. And likewise, you could jump in a pool, like you could be in the shallow end of a pool, like where part of your trunk is under the water, and do jumps in and out of there. Does it do as much as land-based jumping? No, but is it better than being sedentary? Yes. So again, I just think we always have to figure out what we can do.
Yeah, with my ladies, I find that for all of us, we don't realize how much slower we are at reacting. And I think that things like jumping, that works on our quickness and our reaction because it's fast and you have to react to the ground quickly. And so even if you're on a trampoline or, you're still getting that, if you can do it in with any kind of a little more speed than what you normally would, that's one of the things that
yeah, and that's
I
one
like
of the things
about
I
it.
like about jumping rope is that you're having to coordinate a little bit.
Coordinate. That's what I tell my clients when we're jump rope. I'm like, this is why we're doing this. We're working on your brain and your body and your coordination. So, yeah. So for ladies that are listening that already maybe are dealing with some kind of pain, it sounds like that. Well, what were your recommendations be for that lady who's been just dealing with it? Maybe it's a hip, maybe it's a shoulder, maybe it's whatever it is, knees. What do you recommend? Can you speak to that lady who just thinks, oh, I'm scared of surgery, or oh, I don't want to take the time to go get this checked out, or whatever it is that holds us back? What do you think we should? Can you give us?
I think, yeah, I think sometimes women wait a long time to take care of themselves.
Absolutely, we
They're
do.
very happy to call and make an appointment for their spouse or their child or whatever. And
Yes.
I I think that I think a lot of women start to figure out maybe later on, like, oh, I do need to take care of myself. And so I guess I wouldn't wait too long. Like like I said, the number of women I see who come in with really, really stiff shoulders and they've been getting stiff for 3 months. It's hard for me to figure out how they could wait so long, but I know that people probably taking care of other people. So yeah, I think, if you've had pain for, I don't know, more than a month and it hasn't responded to rest or, usual things like a little Tylenol or anti-inflammatory, and it's impacting your day-to-day function or, your things that bring you joy in life, go get them checked out, because maybe there are ways that we can manage or, modify the symptoms so you can still do them, or having information is power, like, you know, uh, getting some imaging, talking to a doctor, letting them give you some guidance. I spend a lot of time with my patients who have just mild arthritis that's, giving them trouble, but at least like knowing what's going on, maybe knowing they're not like harming themselves more by doing X, Y, or Z that they want to do, can help them be more comfortable doing it. And I just think there are so many things that start to crop up that don't go away, and it can be helpful to have information up front in terms of like, what is your condition, what's going on with it, and maybe how you can manage it, or like how you might modify what you're doing to make it less problematic, for you. But I do think there's a lot of sometimes fear in going to a doctor and getting a diagnosis. And I guess people should know that like just because you go and get some information and get some imaging and get some advice, it doesn't mean you're like signing up for surgery or anything like that.
If you had a wish for our listeners today, Jocelyn, what would it be?
I think just to educate yourselves and be proactive about your bone and joint health. Use the tools that you can use for you. We know that as women age, you're going to be more prone to osteoporosis. Definitely over the age of 50, you're going to be a bit more prone to developing things like frozen shoulder or arthritis. And I think just kind of being on the lookout for those things, being proactive, being your own advocate, when you go to see a doctor, just being educated about these things helps so much, because you can, you can do a better job at your kind of shared decision making, if you have knowledge about these things. And I think just knowing that it's like really never too late to start also, especially when it comes to bone density and engaging in exercise and strength training, like we talked about. It's really never too late to start, but knowledge is power, and just educate yourself and be proactive about your health.
And my wish would be that ladies go and get checked out instead of living in pain, and take care of ourselves. Like, we need to, yeah, of course, take care of others, but take care of ourselves. And in the meantime, do the 3-limbed bike while you're figuring out what's going on, and when you get done with getting treatment.
And my wish is knowing that it's not a one size fits all. So what you see on social media might not be appropriate for you, but maybe get educated to find out what is the best course of action to optimize your own health and feel great.
Thanks for listening. You'll find me, Allie, on Instagram at Allie Curve Fitness.
And you'll find me, Shauna, on Instagram at Shauna Kaminsky. Feel free to pop us a DM with questions and or feedback.
If you're enjoying the Girls Talk Healthy Aging podcast, please subscribe and share it with other health-minded women. Ratings and reviews are also much appreciated and help us get our message out to a larger audience.
Until next time, be healthy and be happy.